Hi, good afternoon, everybody, and welcome to the CANS Technical Assistance Monthly Call for April 2019. We'll just get started in just one moment.
Something on glass that was really big. I remember reading it. There was something about a reset something. I don't remember exactly. Not that.
Hi, good afternoon, everybody, and welcome. We're going to start with a quick introduction around the room, and then we're going to shuffle a little bit of the agenda, and I apologize for the inconvenience, but we're going to change up the order in which we're presenting today. So my name is Jeffrey Koff. I'm with the Integrated Services Unit with CDSS.
Leslie Beltran, also with the Integrated Services Unit, CDSS.
Good afternoon. This is Janine LaFleur, also with CDSS. And Lisa Ritchie with CDSS.
Hi, Rich Connect, Integrated Services Advisor to CDSS.
Hi, this is Rebecca Buckley, as Integrated Services Unit, and I want to introduce a new member of our staff, Robin.
Hello, Robin Palmer, new with CDSS, second day. Excited to be here.
She will be a great addition to our staff. So today we're going to change course, and we're actually going to have Victor agencies present first. Based on the polling from previous calls, there has been an interest in learning more about the CANS within case planning. And today we have Megan Murphy and Manuel Luau from Victor agencies joining us to provide the audience with a presentation on the implementation of the CANS into the CFT process and its use in case planning.
Hi, everybody. Can you hear me okay?
Yes.
Yes.
I'm Manuel Luau. I'm a Regional Director for Victor Community Support Services.
And I'm Megan Murphy. I'm the Director of our program in Yolo County.
So in addition to overseeing our community-based programs in the North, I've also have consulted with several counties on and CalSpec on CANS and CFT, and then the integration of the two. So what I hope to do is just give an overview on the direction I've been advising counties, and then Megan's going to give an example of the process of how one county got up and going.
Manny,
so,
this is Lisa.
Yeah.
I'm sorry to interrupt. You are a little staticky, so you're cutting in and out. Yeah, thank you.
I'm going to, how's this, better?
No, it's the same. I wonder if you could redial. Could you hang up? We'll just hold the line, and then you could redial? Because you're on a connection.
Yeah.
It's cutting out.
Pick up the phone. Maybe. Is this better?
No.
Same.
Or is this still static?
Yeah, it's the same.
Okay. We'll redial.
Thank you.
Okay, we'll call right back.
Yeah, while we have just a moment for them to sign back in, we could just do some quick updates. On April 30th, from 11 a.m. to 12:30 p.m., CDSS invites you to register for the Effectively Integrating the CANS into the Wraparound Process webinar presented by the National Wraparound Initiative. The wraparound process is the most common care coordination model for youth with complex needs in their families. Meanwhile, the CANS is now the most widely used assessment tool in public child-serving systems. This webinar is based on shared work of the National Wraparound Implementation Center and Chapin Hall at the University of Chicago to develop guidance and document around the how to best integrate the CANS into the wraparound process. The webinar will be hosted by Dr. Eric Burns, co-director of the National Wraparound Initiative, Kim Estep, Director of Training at the University of Maryland, and Dr. John Lyons from Chapin Hall. The webinar will follow a joint statement from the National Wraparound Implementation Center and Chapin Hall and begin with a brief summary of how differences in the wraparound and transformational collaborative outcomes management, better known as TCOM philosophies, may rise, operational frictions, and problems and practices. Presenters will describe potential ways to effectively coordinate the CANS assessment within the wraparound process, including the do's and don'ts across the 4 phases of wraparound, which are engagement and team preparation, initial plan development, implementation, and transition. That link to register can be found on the agenda handout. And if you have any questions, please feel free to ask in the chat box. Manny, are you back?
We're back. Can you hear us better?
Yes.
Okay. Sorry about that. Thank you. So again, I'm Manuel and Megan Murphy. We'll start off with a quick overview, and then we'll give you an example of one county and one collaboration and getting this going. So I think in this slide, let me switch real quick here. So one of the things I've noticed is happening with the CANS and the CFT process, and it might be just due to lack of experience and knowledge of both of these processes, is that I think we tend to try to have these two tools do more than they are intended to do. And I think those of us who've been involved with the CANS and the CFT for several years have learned how to simplify the purpose of both these processes. And where I've landed with the CANS and the CFT, their predominant purpose as it relates to families is it engages them in the existing services we have to offer. And that's not to say that the CFT and CANS doesn't meet some agency requirements, which it should, and it does. But from a family standpoint, we really have to think about these two tools are intended to engage them in the services and in the process that we offer. So I think first and foremost, I come from that perspective. So as I teach counties and providers, is what you really want to do is evaluate, has the CANS, has our CFT process engaged families? Or are we just checking off the box? So just know that that's the backdrop of how I teach folks as I move through this presentation. So here's why I think engagement's important. We first and foremost have to acknowledge that the families we work with are involved in multiple systems. So if we consider the first system that most of the children we work with have to be involved with, that's education. So the education system itself is intended to teach kids and educate them. And if children, students struggle in the system, they have a process, they engage families that can eventually lead to an IEP. A lot of our students that we work with may also be involved with the mental health system, which if you're a Medi-Cal recipient, if there is medical necessity, a client plan is developed for these families. So right there in just this snapshot, let's acknowledge that if you're a child, a family who has an IEP and a client plan, you now have two plans in your life. And unfortunately, sometimes these two systems don't talk to each other. And so then that creates the first dilemma for families. The other system our families work with is child welfare. And in child welfare, if there's significant harm and danger, this system will create a plan for them too. And so now we're adding another plan in the lives of the families. And they're often, with the families we work with, there's a likelihood both of these three systems are going to be involved in their lives, which may mean there's three plans in their lives. Let's add one more system, which is the reality for some of our families, is if they're involved in probation, that system exists, protects society. And if there's enough risk, a plan will be developed here too. So it's likely that the families we work with will have all these systems in their lives, or several of these systems. And each of these systems have their own requirements, their own language, their own systems and processes. And the family is in a situation where they need to learn to navigate us and our systems. And it's almost like the systems are trying to have the family understand our plan rather than how it should be, which is these systems need to understand the family's plan. And so I think we first have to acknowledge that families get disengaged, and it's not because we're not trying to help. It's that we tend to take an approach of more is better. And more is not better. Better is better. I think we first need to start with understanding the family's plan and acknowledging that each of the families we work with have a plan. They were functioning way before we came into their lives, and they're going to function after we're gone too. It's our systems that tend to label their how they function as dysfunctional. So with that said, the CANS and the CFT is intended not to replace the services that are offered by these various systems, but it's there to help engage them in the services and create similar language and one plan if we can. So this is why I say the CANS is more than an assessment or communication tool. It should be engaging families. So one of the mistakes I often see is we treat the CANS as an event. So I often hear, when are you going to do your CANS with families? The CANS should not be a moment in time. It's a process that evolves within the context of our relationship and our assessment and engagement process with families. When we do that well, it makes the assessment process transparent and meaningful to families. Transparency is extremely important in the work we do with families. And unfortunately, because the assessments that we do in our various silos, it's not as simple as just hand them the assessment. So we need a way to synthesize the information from the assessment so it's digestible and meaningful to families, and the CANS can do that for us. Ultimately, what it also can do is create an opportunity for conflict management. And the reason I call it an opportunity is because I think we need to seek when there's dissonance between how we're seeing it and how families are seeing it. And that gives us an opportunity to have those meaningful discussions. If we're doing the CANS well, we should be seeing an inverse in the hierarchy or move the power from the providers to the families. There is a hierarchy in the system of care, whether we want to acknowledge it or not. The tendency is for professionals to make decisions on behalf of families, and families know this, and they understand this, and they adapt fairly quick to this. And it's not that they lose their voice or their choice, it just gets diluted the more that they start experiencing us making decisions on their behalf or us prescribing what we believe the needs are for them. So then how do we measure that if this engagement is happening? I think that these four are key indicators that we can get better at evaluating at the end of each CFT or when we're working with families. I think that if we're doing effective engagement-oriented CFTs, it should feel like there's effective teaming and collaboration going on. The family should experience as a strength-based. Their voice and choice should be promoted throughout the CFT process. And again, you could just measure this by sitting in a CFT and see who's talking the most. And then lastly, we're talking about needs, not just symptoms, needs. Those are two different things. If we're truly being needs-driven, they get to be the author and the expert of the needs. We don't get to prescribe needs on families. So we should see these 4 indicators in CFTs if we're striving for engagement. So here is a format that I've been encouraging folks when they do their CFTs. And in following this format, you can strive for those 4 indicators I previously talked about. I tend to think that any child and family team, regardless if you're in mental health model, wraparound, or in the child welfare CFTs, has 4 components. So the first component is we need a purpose. You technically can't call yourself a team unless you have a common purpose. And so in order to create that team or that collaborative indicator I talked about earlier, I think a CFT has to be very clear on its purpose. For me, a purpose has 2 components. What's the reason we are bringing this group of people together? And for the purpose of a child welfare CFT, there was a harm that occurred and there's a danger. And I think that sometimes we, for whatever reason, are scared to talk about this topic in a CFT. And yet I think it's extremely important because we have to acknowledge that this is what's bringing us together. And again, it should be consistent with transparency, which should be happening in our assessment process. So let's just talk about the harm that occurred. There's nothing we can do about it. And what is the danger that has us concerned? Once we have that, and we're all clear about that, we need to ask the family, what's the change they desire? This is their vision. Those 2 components together will create our purpose. Now, what can happen is there might be some dissonance between those 2 things. The family's vision may be way off from the things that are concerning us. If that's the case, then it's a good conversation here and now. So once we have a purpose, the team all knows why we're here. We can then move into what are our resources and functional strengths that can help progress us towards the vision. What I tend to do is have folks introduce themselves, not necessarily just by their title, which is important, but how can they contribute to our vision? So your ability to contribute to the vision of this team is not title specific. I tend to think that a natural support can meet the same need as a professional support. So I have folks introduce themselves and say, what is your contribution to the purpose above? This creates functionality to the why they're attending. It can organically start creating strategies. You can have an uncle who says, I can provide somewhere to live. Now, even though we're not at the strategies yet, a skilled facilitator should be able to eventually be able to connect the dots for that. The next thing you can move towards is, once we know why we're here, who's on our team, what do we need to focus on to progress towards our vision? This is where the CANS has a very important role. The CANS can then present specific needs that are directly related to the purpose. What we tend to do is be able to share the priority CANs in the CFT, so they get put up on the board, and then we allow the family to tell us, of these CANS items, which do you believe we need to focus on first to progress us towards your purpose? This empowers the family to be able to identify which of these needs are the most important to progress them towards their vision. Once you've isolated specific priority needs, you can then ask who of the contributors can help us with these needs. This is where it's really important that the facilitator has isolated every contributor and what they contribute to that vision, because organically what will happen is strategies will surface. So each need is connected to a person. Then we design strategies with those two in mind to progress the vision. We would go through as many needs as we need to that the family or the CFT thinks are important to progress the vision. What this will all summarize towards is a plan. So what we should walk away from each CFT is a clear purpose why we exist, who on our team can help us, what are the priority needs, and what strategies can we put in place to ameliorate those needs, and in doing so, we're progressing towards our vision. So this, what I just introduced to you, is a way to start your child and family team process. Typically, this is what that first child and family team meeting looks like, that is helping inform your case plan. And again, if the clinician is sitting in the CFT, it should be informing their client plan too. This child and family team meeting should progress through the phases. So even though early on we're focusing on engagement, that child and family team meeting is going to evolve throughout the different phases that we're working towards. So if after our first CFT, we decided we're going to focus on 4 priority needs from the CANS, the next CFT, we're checking in on how that's going. And what might happen is some of those might have progressed to where they are no longer a need, and we've progressed towards our vision, or it might be that there are new needs that we need to plan around. And again, we need to have the right people in place at that CFT to help us progress that process. So this is easier said than done. And so I want to just talk about some prerequisites before something like this can work for a county or a community. I think that if what I just described is going to work, it requires us to have a focus on engagement throughout the process. And so again, a family needs to be engaged in the CANS prior to attending the CFT. They should not attend the CFT and this is the first time they've heard about the CANS. So if you are the person responsible for doing the CANS with the family, then it is your responsibility to have engaged them and help them understand what these items and their needs mean, because we will be talking about it in the CFT. I think that the other thing is we have to develop a culture beyond inviting natural supports. Sometimes what I see is we have an invitation system where people are invited to the CFT and they don't know what they're showing up to. I think we have to engage them in the process. We have to have relationships with these folks. So there has to be some outreach. So go beyond a system of inviting people. Let's engage them in the process. What I described to you requires trained facilitators. I think facilitation is a skill set. I'm not one to tell folks that your role will inhibit your ability to facilitate, because I don't believe that's the case. What I do believe should be the case is folks should be trained in how to facilitate the process. And it should be beyond training. They should have a focus on development, their trade, and their skill. There needs to be some field supervision, some observations, and they need to keep trying to sharpen their saw. What I am seeing starting to happen is that there's 2 processes that are occurring. So the CANS process in some counties is being done by behavioral health, and the CFT is being coordinated by child welfare, which can work. However, we need to line up the timelines. So if we're going to have the CANS inform the CFT, then the steward of the CANS needs enough time prior to that CFT to do the CANS process. And remember, it's not an event. It exists within the context of their engagement and assessment process. And they need time to have engaged the family in the CANS results and do it with them, so that going into the CFT, they're informed and ready to be successful at the CFT. So the two have to coincide, the timelines. We have to move to a place where there's only one CFT, one CANS. I think the challenge with this is that prior to this requirement, there were already existing CANS and CFT models out there. Wraparound, for instance, has been doing CFTs for quite some time. And so what's happening to us RAP providers is we've had a way of doing our CFTs. I think that we now as RAP providers need to align our CFT model to the county CFT model. It doesn't make sense that families are going to experience this front-end CFT from child welfare that's going to be completely different than wraparound CFT. And beyond the style differences, we need to create a continuum from that first CFT into any subsequent CFTs. So if that original CFT generated a child and family team plan, why should wraparound start from scratch? There should be a continuum. And so this will require that in a county, it's not just about the county having a child and family team model. We have to bring providers into the fold. Lastly, I think we really have to share the intent to inverse the hierarchy. It's not just the facilitator's responsibility to try to promote voice and choice and other elements that inverse the hierarchy. If you are a professional and you're attending a CFT, help the facilitator help the process. It's unfortunate when we professionals become obstacles in the child and family team process. So we all have to be aligned with this inverse the hierarchy model. I'll pass it over to Megan now, who'll talk about a model that we've been doing.
Thank you, Manuel. So again, my name is Megan Murphy, and I'm the director of our programming that we're providing in Yolo County. And I'm going to walk you through a little bit of where we are in the implementation of providing these CANS-informed CFTs for child welfare. We've been doing this in some other counties, and so I'm going to let you in on our process here. I don't know how many Brene Brown fans I have out there right now, but we're going to do a little bit of courage and vulnerability work and let you in on something that's in that cooking phase. We're still building. So I'm going to talk to you about how we started, what we're doing and where we are and where we're planning to go. So first, we want to start with getting the right departments at the table. Yolo County met with a consultant who was Manuel here with us today, and really looking at a gap analysis of what the requirements were from the state to provide these CFTs and start providing the CANS to children and families to guide that process. And they started looking at who really needs to be involved, who's getting at the around that table. So child welfare and behavioral health, really looking at what the current needs were, what the needs needed to be met, and then filling in those gaps in the middle there. I lost my mouse, hold on. There we are. So we're still in the beginning phases of this partnership. We started doing trainings with all of the departments in December, and we started receiving referrals in January, providing the CFTs in January and February. To date, for our February and January numbers, we had 54 referrals come in, and we were able to complete 32 requested CFTs. Some of those were requested for that same week, and some were requested down the line. So looking at meeting that need, providing the facilitation of those CFTs, and building that partnership.
Can I share that one of the experiences I've had about Yolo County is they involved every single system partner, Office of Ed, We had every director from all of the school districts were at this training. They sent their school counselors, probation, and so it was very inclusive of the different systems. So they all heard the same message at once.
Mm-hmm. So we start to build a little bit more, learning that training and repetition are key components. The training that Manuel referenced wasn't a first-time training and wasn't a one-and-done training. We had some smaller breakout trainings with CWS staff, CPS staff, as well as children's mental health. And Manuel mentioned earlier having facilitation be a skill set. You need to have well-trained facilitators. We're also aware that you need to have well-trained participants. A large process of the CFT is knowing what your role is. So really training our referral sources, our child welfare workers, and our behavioral health staff is really, really important so that we have knowledgeable partners at the table as well. This county also has been involved in a multidisciplinary CFT work group involving all of those key components. So our facilitators attend, department leadership from child welfare as well as mental health, and parent partners meet monthly to review what we've done, where we're going, and fill in gaps. So far, we've had 3 of these meetings. We've already made changes to our referral process, the information required, the timelines that we're looking at to receive referrals and to turn around those CFTs responsibly. We're working more in that work group to kind of pull that curtain back and help one another in supporting the families to know the purpose of that CFT. Manuel mentioned earlier that timeline and turnaround, that oftentimes we're finding that we have inconsistency in how much time we have to prep families to begin that engagement phase, and also to complete a CANS. Currently, that CANS having been completed before that CFT happens some of the time. Oftentimes we're working to kind of do a live CANS of some primary domains in order to inform that CFT, and the behavioral health is working to fill that in on the back end. So that's a huge portion of looking at from our model to reality and how we can make those two be more in alignment. We're also looking right now at increasing the capacity of staff and facilities, bringing on additional facilitators to meet the need. We had referrals trickling in the beginning, and now we're receiving them daily, which is fantastic because we know that need is out there. So now we're working to simultaneously increase referrals and capacity to provide facilitation services. And we continue to refine this process together. Communication is really, really key amongst all of our team members. You know, small things from making sure we have name tags at those tables. So oftentimes we're meeting with folks who haven't met before in the same room together, which is such an important piece of this process when we're working with children and talking about their permanency. It's really helpful to know who's sitting at the table with you on your team. You know, small things like name tags to big things like ensuring that we have the CANS completed and have those processes in place even before we come to meet at that table. We're also looking at ways to include natural supports from the beginning, engaging with families before we come to that table together, and working with all of our team members who all have important pieces of information to bring to the table so that we can work comprehensively together.
A couple other key elements that this county is working towards. We acknowledge that prior to this requirement, there were already existing child and family team meeting structures, and they agreed to have a similar structure. So if you're in a behavioral health, quote unquote, KDA CFT, then the structure looks very similar to the child welfare and the wraparound CFT meeting. So that families who have to navigate these multiple systems will have a very different experience. The other thing this county's done, which I think is excellent. They've done great partnership with community-based organizations. There's another organization, Stanford Youth Solution, who's providing the parent partners. So those parent partners are responsible for engaging family finding so that the CFT has foremost supports that are engaged in the process. And Victor is doing the facilitation while behavioral health does the CANS. So you can see the various parties involved to get this process aligned. Thank you. And any questions? Hello? Hello?
I just want to say I think you did a great presentation.
Oh, thank you.
Thank you.
And there is somebody here in the audience.
Okay, good.
So we're talking to ourselves.
We already know this thing.
Hi, Victor, can you hear us? Manuel, can you hear us talk?
Yeah.
Manuel, can you hear us?
Yeah.
Oh my gosh. Everyone's unmuted. Hello?
They have us on mute.
We're here.
We can hear you.
You're not on mute. You're not on mute.
Oh, good. Okay. So we'll read the question again.
Okay. Which staff are you training to facilitate the CFTs?
Sounds like that's a question for Megan.
Yeah, for Megan, for Yolo County.
Yolo County?
Yes, so we have a specific position called Facilitator, and those were formerly MHRS staff who have bachelor's degree plus a number of years experience. We also, so that's kind of their classification. When we're hiring for this position specifically, we're really looking at folks who have a high degree of organization, a high level of passion to support permanency for youth, and folks who are comfortable with uncomfortable situations, able to kind of juggle some hot feelings that come into the room and maintain control over a process, and to be very, very clear about boundaries for those processes so that meetings can run smoothly. I hope that answers your question.
Okay.
This is one about the attorneys.
We do have another question, Megan. Are you inviting the children's attorneys to the CFTs?
There's no reason we wouldn't. I think that what we try to do is what's important is that your participation here has to be aligned with the purpose. If you have a different purpose you're trying to accomplish, this might not be the right meeting for you. So there isn't like a rule that says we wouldn't. Invitations go out to whoever's important to the family. And then what you'll probably run into at CFT, somebody has their own need and want to have a different purpose of this meeting. The trained facilitator can help them set up a different meeting structure for that. So in this county, there's no particular reason why we wouldn't. I have bumped into some counties where, for whatever reasons, they choose not to, and it might be more related to the relationship or particular folks' approach. I think that they need to tackle that, and they need to discuss what's the real need here. Why aren't we? If it's somebody who can be helpful to the purpose, why not?
That's Richard. I think I would just remind folks on the call that the state has put out some guidance under All County Information Notice 1823, probably 6 months ago.
Yeah, 6 months-ish.
Yeah.
No, it's actually an all-county letter.
It's an all-county letter, thanks. And I think there's some nuanced guidance in there. I liked Emmanuel's answer. this really takes us back to engagement, right? If you have a welfare authority that has a relationship with family counsel, the lawyers for your families, that is highly conflicted, that is characterized by a misalignment of approach or intent or purpose, you've got some work to do before you can necessarily have them routinely participating in your child and family team meetings, because the experience from some counties is that by having attorneys necessarily kind of uniformly in the conversation without relationships, without an alignment of interest, that it can reinforce the conflict and the dissonance. Very difficult to align objectives if that's the case. So before you kind of uniformly make a policy that you will or will not invite counsel into child and family team meetings, I think we would just encourage a real thoughtful consideration at your interagency leadership team and with department heads necessarily and with your contracted attorneys to make sure that they understand the purpose of the team meetings and that they can support the family's agenda in working towards resolution.
I think that one of the challenges folks have is when they attend the CFT, they're not very clear on the purpose of this process. And so the facilitator's ability to make it very clear what the purpose is, and then asking them, how do you, your title's great, but what is your contribution to this purpose, helps them stay aligned.
Any other questions?
Yeah. We have another question. How do you go about sharing substance abuse info considering the 42 CFR Part 2? Do you get releases?
Yeah, there's a release up front. So this county is following the state MOU that was passed.
Okay, thank you.
We have time for one more question.
Go ahead.
It is a big topic. There are other counties that are struggling with this, and it might be because sometimes county council wants to regulate themselves. My advice is follow the state issued MOU.
Right. Okay, thank you, Manuel.
Thank you, Manuel. All right, we have time for one more question for Victor agencies, and then we're going to move on. Would you like to ask that one?
Is everyone unmuted? Let's take one kind of line.
There's one right here.
Okay. At this time, are you removing the FSMA and the CSNA for CANS? I think that question is for Megan.
I could help her. So no, that's my knowledge. No county has done that yet. So this county has not taken an approach where they replaced it. They're both being done, and they should inform me. I mean, if you're doing them both, they can both coexist, in my opinion. Because remember, the CANS is not a separate assessment process. It synthesizes your existing process. So if you're the child welfare worker and you've done a family strengths and needs assessment, then it's just going to inform your CANS and make it more digestible or easy to understand for families and create that transparency we're supposed to be working towards. So I know that we're working towards the removal of it. I tend to believe they can coexist.
Thank you, Manny. Just for reference for folks, CDSS did issue a letter, ACL 18-81, that does identify that CANS is now taking the place of the Family Strengths and Needs Assessment and the Child Strengths and Needs Assessment. So that letter provides clarification, but as you've pointed out, regardless of what assessments or tools are being completed, the CANS really is a communication tool and a way to organize that information. So thank you very much for your presentation today. Some great information, and I think the slides, Jeff, are they available for folks to download?
Yes, so we are going to, there seems to be a little bit of technical difficulty with downloading it. We will send the slides to the email after today's meeting. If you are interested, just send a message in the chat box that you would like to receive it, or we can just send it out to the group as a whole. At this time, we're going to have a presentation now from San Diego County on their CANS implementation. We have Shelly, Paule, presenter.
I'm going to share my screen and switch over to the PowerPoint. Can everybody hear us?
Yes, we can.
Awesome. All right. Let's see. Does that work? Okay, so my name is Shelly Paule. I'm a social worker with Child Welfare Services in San Diego County. I've been a social worker for 20 years. I'm also an LCSW, a certified CANS trainer, and I'm the policy analyst in charge of the CANS rollout for Child Welfare Services, which includes the training rollout for our 800+ staff, writing the CANS policy and forms, supporting the ongoing training and staff as they have questions that come up, and basically being the cheerleader for CANS to benefit the children and families to meet their goals.
Hi, and I'm Eileen Quinn-O'Malley. I'm with the Behavioral Health Services in San Diego, and I'm the Behavioral Health Program Coordinator, and currently I'm the lead for Behavioral Health Services. My resume is not as impressive as Shelly's, but we'll just move into the presentation.
Totally untrue, by the way. Okay, let's see. Oh, I'm trying to advance my slide. Oh, there it went. Okay, so we serve 3.2 million residents in the county of San Diego, and we have a vision for the region that every resident should have better health, live safely, and be thriving. The vision of CANS, as well as the child and family team model, fits perfectly into this vision.
So we thought we'd start with a broad overview of, our CANS implementation and some of the pre-existing mandates that it supported this collaboration. So one of them being the integrated core practice model. And so in the county of San Diego, this practice has really assisted with understanding, integrating, respecting the values between our partners, which is CWS, BHS, and probation. And ultimately, this has had a positive influence on the care and services for our shared population and to achieve the goal of permanency. The pathways to well-being within BHS and the child welfare practices with CWS, again, has enhanced our collaboration, and we have been working very closely with this CANS implementation. For behavioral health services, the training, we started planning around September 2017, and we had an implementation date for rolling out the CANS for July 1, 2018, which meant that all of our trainings for our providers had to be completed by 7/1/18. So within that year, which is last year, at least 600 behavioral health service or organizational providers were trained and certified to administer the CANS. And what we had 4 in-person trainings with Create Foundation with Dr. Lyons. 3 of those were specific to training on the CANS, and then 1 was supervision focused because our goal was to create a super user group. And then this super user group was going to be our champions within the county of San Diego. We met on a regular basis, and the initial meetings really focused on some of the challenges, what was going well, a lot of questions. This is new to our entire system of care. But to date now, we meet bi-monthly, and the super users have really enhanced our ability to focus on what we want the CANS integration to look like within therapy, within clinical supervision.
I'm sorry to interrupt you.
Can you hear me?
Sorry to interrupt you. Yeah, there's a fair amount of background noise, so I just want to ask folks, if you're not presenting, to please put yourself on mute. Thank you.
And then lastly, we utilize the super users to assist with bringing the CANs into therapy and focusing on the interventions within family therapy. As well, with our effort to align with CWS, this upcoming fiscal year, we will be rolling out the early childhood CANs, the 0 to 5, as well as our fee-for-service providers will start to utilize the CANs. And so we will have 2 trainings in May and June with the Parade Foundation again, with the ultimate rollout of 7/1/19 for the CANs and the fee-for-service, the early childhood CANs and the fee-for-service. We are also working with CWS because they have an incredible pass rate, and so for our upcoming annual recertification for our current BHS providers, I'm working with Shelly to get some of her tips and tricks on how to ensure that our providers are recertified fairly easily.
And then for the training and implementation for child welfare services, we did a staged rollout starting in September of 2018, where we trained our Pathways to Wellbeing workers who complete the intake assessments we'll talk about in a little bit. And then we initially trained all of our case management workers and every supervisor that had to be certified. So over the first 5 months, we trained and certified over 350 staff. Now, starting in April, we're starting to train the emergency response workers and the non-case carrying workers who are not requiring certification from at this time, but as they change programs, we're having them certify. We've been very lucky. We've kind of worked out a system where we're having a 96 to 100% pass rate per class. One of those strategies that is very effective and that the Parade Foundation has supported is that we're having them take the test as a group, or in groups actually, so there's usually 30 to 40 people in the training, and then they pull up their vignettes, and then we have them group into their vignettes. And then they go through the CANS tool and they have the discussion about it. What we found is that when they're working together in a group, just like we do in the child and family team meeting, they're coming to consensus, and it kind of brings the outliers into the norm. So, you know, we have some people who are always leaning towards 0 and some people who are always leaning towards 3s, and together, when we work as a group, we're getting to a very high consensus and having a better discussion about the manual, how the manual really guides us, but the action level really helps us determine the final action level or rating. Once they're CANS certified, the assigned social worker is completing the CANS conversation in the CFT, and they create the updated case plan with that. All right, so next we were going to review how both of our systems complete the CANS. So I'll start with behavioral health. And so our providers are required to complete the CANS at intake, which is within the first 30 days of an open assignment. And we really encourage our clinicians to use that assessment session to gather all the information, hear the family story, and summarize it. So then during the client plan session, this is when the CANs are actually discussed and shared with the families to then inform treatment and ultimately what the family would like to achieve. The other time points for completion of the CANs for BHS is our utilization management cycle, which is we are on a 13-session model, and at that point in time, providers just need to show that there's continued medical necessity for ongoing treatment. And then the last time point is at discharge. And ultimately, the CANs need to be completed at a minimum every 6 months. So the sharing of the results with the client and family, this is the area that we are working very closely with CWS on. So as I stated, ideally during the client plan session, this is when the CANs results are shared with the family. We have created here in San Diego County a CANS family letter, which was established so we have a standardized way for our providers to explain what the CANs are, the purpose of them, as well as that
the CANS results will be shared with CWS or probation if they're involved with either one. And so just to provide them that understanding that we do have transparency between our systems. As well, we have also inserted in our client plan a confirmation page for our providers to complete that they have verbally shared the information or the CANS results with the family, which can include the CANS tool, or we also have assessment summary, which was developed by our research contract.
Great. And then for child welfare services, the way we complete the CANS is that within 30 days of a new case opening, either a voluntary or a court case, the case is provided secondary assignment to the Pathways to Wellbeing Protective Services workers. These workers exclusively do these intake mental health screenings, which are the CANS assessments. They review the documentation in CWS CMS, the contacts, the court reports, all of the supporting evidence. They do a pre-interview with all the CFT members, which includes an explanation of the CANS. So when they get into the CANS meeting, the CFT where we're going to have the CANS conversation, there's really no surprises. Everybody's ready to do that. They pre-interview in person with the child or youth, and then they take all of that information, including the BHS CANS, if we have one, to inform their pencil score that they use just for themselves in the child and family team meeting. What we do is they then lead the CANS conversation and together with the CFT members finalize the action levels. The way we do this is that we don't say, okay, I think it's a 2. I'm the expert, the child welfare worker, and I think it's a 2 in depression. What do you all think? We know that would really influence people's input and they might defer to our authority. We want to be coming to consensus. So what we do is, in order to not go through all 62 items individually, we say first, based on our pre-conversations, there were no worries about these areas: anxiety, sleep, oppositional defiant disorder. We go through all of those. Is that still correct? Yes. Then we mark those as 0s. And then we have discussions about everything that's not a 0. So if there's a concern about depression, we talk to the team about that. We have the manual present in the meeting, and we go through that. Then the facilitator notes the case plan items and the service referral items on the CFT action plan summary that's provided to all the family members. And then the subsequent CANS assessments and case plan updates, the assigned social worker, so the primary social worker, will lead the CANS conversation in those CFTs. We're scheduling those the month before the court report is due. So if the court report's due in June, in May, they're scheduling the CANS CFT conversation to work together to determine the action levels and how to update the case plan and what service referrals would benefit the family. We also have a family letter that we can share with you. I apologize we didn't send those in advance, but we're going to send them, and they said they would distribute them. All right, so CCR teaming, we work together, Behavioral Health Services, Child Welfare Services, and Probation to have a joint contract for the facilitation services. Fred Finch won the award. They started, I believe, in April of last year, and we actually rolled out, they started implementing CFT facilitation in August. So my team was very impacted by the fact that we rolled out a new facilitation contract, and then on October 1st, we started these CANS conversations in the CFTs. So I don't recommend doing everything at once for your teams, but it's all working out. We meet together regularly to troubleshoot issues, and we really remain committed to the teaming process and the transparency process. Not only do we want that for our families, we want it between our organizations.
So as Shelly mentioned, the CFT facilitation contract was awarded in April, and so since that time for behavioral health providers, they have utilized that program for all of their CFT meetings, which has been a real benefit for them. So they're able to focus on more of the therapeutic role that they have with the family, as well as we're really encouraging them to share the CANS, and this would be if CWS was not present or involved with the family. So CWS has been a real role model on how to utilize the CANS within the CFT conversations. So for the BHS providers, as I stated, the CFT facilitation contract will organize and facilitate all CFTs, and this includes our enhanced youth under Pathways to Wellbeing, as well as those families or youth that just request a CFT meeting. So as I said, this has been a real supplement to some of our services. But as a note, our wraparound providers still choose to facilitate their Pathways to Wellbeing Child and Family Team meetings, which happens at a minimum every 30 days. And then for child welfare in San Diego, we do use our contractor for all out-of-home use. So we know that having a neutral facilitator is great for families. We've definitely heard positives about that. And we know that when we're impacting families the most is when we're actually removing their children from them and impacting their lives. So right now, that's when our contractors are used. They're averaging about 400 plus CFTs for us per month between the three primary organizations. And then child welfare still supplements with internal child welfare facilitators who do all of the CFTs for the children that still live in the home with their parents. And that includes our emergency response CFTs, in-home voluntary, and family maintenance CFTs. We do have a universal referral form. One of the things we think is great is that BHS providers and child welfare and probation, as well as the RAP providers, all use the same referral form for the child to request a child and family team meeting. All right, so CANS and the CFT. When we have the CANS conversation varies. One of the questions I get the most from other counties is, where do you do it in the CFT? And what we do, we make it part of the agenda, but we don't put it in a prescribed place. So our first, the Pathways to Wellbeing workers who have done the original intake, initial referral, sorry, I just lost my train of thought. The original CANS conversations in the CFTs were really feeling it out for us because when we created this model, we hadn't really done it in practice. So what they have found over time, and they've done over 200 of these CANS conversations in CFT meetings so far since October 1st for new cases, is that there isn't a perfect place. It varies by family. So some families, they go through the what's working well, the worries, the Pathways to Wellbeing worker is kind of updating their pencil score as they're listening, and then they go through the scoring with the family. So they complete that conversation and they finalize the scoring with the family. We actually provide every member of the child and family team with a blank laminated copy of the CANS and dry erase markers. They really enjoy following along. It gives them a visual. It helps them kind of understand the process. But then we collect them at the end and we wipe them clean. We really felt like it was too much to give a copy of the finalized CFT to every member of the CFT. For them to walk away with the confidential information or a neighbor to walk away with it, or perhaps a teacher, it would just be too easy for them to accidentally violate that confidentiality by leaving it out somewhere, nor have we had anyone request it. Of course, parents and the child receive an actual completed copy of the child and CANS, but we have found that this laminated version works great for all of the other participants. The person who completes the CANS interviews and initial scoring kind of shares, like I mentioned, about all of the zeros. We get through those, and then we move on to the other items that need to be discussed in further detail. Had a lot of positive feedback from families. We're seeing a lot of positive outcomes. We're not seeing power struggling over the number. We were worried about that. We have the manuals there to open up and have discussions, and then we talk to them about the action or no action. We had a 10-year-old boy with many examples of this, but one that really resonated with me because one of the facilitators told me about it. Was this 10-year-old boy was silent for the first 45 minutes of his child and family team meeting other than introducing himself. And then when the time came to have the CANS conversation, he became incredibly engaged. He went through every item, asking questions about what's a 1 for depression, what's a 2 for depression. He was actually scoring himself a little higher than I think we would have in the absence of his input and information. And that's been a consistent experience. We are seeing the entire team
the families, the natural supports, the formal supports, and the youth and children get involved in this process, which is really what the state hoped for, and that really seems to be happening. We've had exactly 2 incidents out of 200 where we've had a parent disagree completely with one of the items. One was substance abuse, and one was safety in the home. It was sexual abuse. And we listened to their position, and then we put it up on the action item. The rest of the team agreed it was still a 2. So we put that up on the action item, but we noted right on there that the parent disagreed with that. And then we're including in the court report when we're adding an item or scoring an item that the parents don't agree with, or the child, and making that clear so the judge is aware of it.
So moving forward with in real practice and the positives, and I think Shelly mentioned a lot, for behavioral health providers, I think one thing that has really been highlighted is the importance of family involvement in treatment. And many of our providers, they initially are treating the child, and so with this CANS discussion, it really has enhanced the need to incorporate the families and be transparent and really discuss some of those hard issues that we noticed that they may have shied away from before, but this really helps to just keep it objective and just look at it from the lens of, ultimately this needs to be addressed to reach the goal of, permanency, or whether that be just stability within the family. So that's the positive that we're seeing within the behavioral health system.
Absolutely. And for child welfare, we've talked about the increased transparency. Families understand their case plans better. They're getting into services quicker. I mean, that's the best outcome we could hope for. And we've also found that the natural supports and the formal supports are understanding the case plan better as well, which tends to make them more supportive to that process. I mentioned the reduction of power struggling. I absolutely think we're seeing a reduction of the experience of shame or blame on behalf of the parents. We're not really getting into, the nitty-gritty of the protective issue, because that's clear to everybody. They are aware. We've talked about it under the worry section of the CFT. We're really just kind of talking about the factual information and whether or not that needs action or no action. So seeing a lot less shaming and blaming in this child and family team meetings. We have noticed a significant increase in referral for children. So, the state states if their child receives a score of a 1, 2, or 3 on the behavioral and emotional needs domain, that they'll receive a mental health assessment. In San Diego, what we've decided is if the children scores only 0s and 1s in that section, then we refer them for a mental health assessment. They meet with a therapist and do a complete intake to determine if they would benefit from other services. If they're scoring a 2 or a 3, we see that they need action, so then we're referring them straight to therapeutic services. Just for perspective, from October to December of 2018, we did 128 CANS conversations on new cases, and 118 of those scored with a 1, 2, or 3. So we're seeing a much higher rate of referrals for mental health services. Prior to the implementation of the CANS, we had about 30% of our kids in mental health services, so having a significant increase. We're hoping that this is going to increase appropriate diagnosis, help them regulate their emotions and behaviors, reduce change of placements, increase their ability to cope, and really lead to better outcomes at school, in visits with their parents, and ultimately to returning home as quickly as possible whenever it's safe. Okay. And then for real practice worries, the assessments are going well. One of the things we've run into is that it's difficult to get all of that pre-work done and schedule the CFT and have the CANS conversation prior to the jurisdictional dispositional hearing, which all of you are aware comes up very quick. This is one of the reasons we decided to have the pathways worker do it. It adds about 6 hours of work with those pre-interviews and getting all the information. So the pathways worker, we're having about a 50% success rate completing that prior to the JD hearing. When we don't meet that, we've been having conversations with the judges so they are aware, and all the attorneys. We're submitting them by ex parte or at the settlement conference. The judges and attorneys have been very supportive. They want us to build the case plan off of the CANs. They don't want us to make the old case plans. So they've been willing to do that. And of course, we're working on increasing our capacity as well.
Another worry that we've encountered is the one CANS per child. And so in our county, we actually have two different CANs. And so CWS uses the IP CANs, and so BHS uses the San Diego CANs. Many of the items are similar, but for BHS, we have additional modules that have some sensitive information. So, for example, some of our additional modules are substance use, and I think it's sexuality. And so these are areas where clinicians are feeling that they need to use their clinical judgment whether or not they are going to be transparent or share that information, even if there is CWS involvement. So we're still working out some of the kinks with how to share this, and do we redact some of the information on the CANS tool within CFT meetings, because we know the clients do not want that shared. The other concern is that recently we've had a request from a judge to insert a copy in the court report of the CANs, but it is only for the IP CANs. And so we need to be very clear that our behavioral health CANs are not attached to the court report. So this is where the strong collaboration comes in. And then again, if there's any changes when we're sharing the CANs, so if BHS completes the CANs after they review the CWS CANs, and then we send the BHS CANs back to CWS, then the child and family team meeting needs to be informed if there's any significant change. So just learning how to be really streamlined and that continual communication about any changes.
As Eileen mentioned, our presiding judge, Eileen, and I went and trained the mental health team, the presiding judge and lead attorneys, and CASA was there. And they advised us that we would start attaching the CANs to the court reports. Of course, the minor's attorney and parent's attorney want that as well. I objected. I thought I made a beautiful argument. Why not to? They would know everything that happened, because if it was a 2 or a 3, it'd already be part of the case plan. And if the parents didn't agree, we would clearly put that in the court report. But the judge is the boss, so we are attaching the IP CANs. Just working hard with our legal partners to have good relationships. Our minors attorneys and parents attorney leads actually roll up once a month any concerns they have about the CANS process, also what's working well to me. So that information really helps me know how to train, where to train, what support staff need. Did you want to talk about
the collaboration?
Oh, and the staff and provider response has improved over time. Initially, our staff and providers were really worried. They were so worried about how families would feel in this meeting and how they would feel if we were scoring them. We were all worried about that. But that fear has not come to fruition. We have not had one family complain about the process. Again, they're very receptive to it. They understand the reason for their case plan better. That worry hasn't been valid, so that's great if other people are worried about that like we were. And then just shifting the culture takes time, patience, positivity, and realism. We're constantly getting feedback about what works and doesn't work, and we're open to that. I like to tell my team, I wrote this policy when it was just something in my mind, right? So obviously it's going to be improved and corrected, so we're always receptive to that. So in closing, and I know that we've really stated this over and over, but collaboration truly is key. And so, again, like I said, Shelly and I, we really work closely. We've had several trainings that we've done together, and I think that we both learn a little bit each time that we conduct the trainings and understand our systems a little bit better. And so some of the trainings that we have jointly trained on would be our internal BHS and internal CWS. We've also done some community trainings. As Shelly mentioned, we did training for the judicial mental health meeting, at the CYF program manager meeting, the joint law office training, and so the rest are on the slide. So it really has enhanced our ability to understand systems and really work towards this transparency, which trickles down to our providers and then the families. Agreed. And then we just want to leave you with our top 2 San Diego mottos, because anyone will tell you I walk around, I have a shirt that says this. Yes, we can. And Viva la CANS. That's it. Any questions?
There are plenty of questions.
Uh-oh.
That was a great presentation. Thank you both. Thank you so much. Lots of interest in this topic. So we have some questions that we are going to see if we can fit in right now, and then others that we might have to follow up with.
Okay.
Who facilitates CFTs for those placed in a different county?
So if it's a border county, then our facilitators do it, either Fred Finch or the internal. And then if it's outside of a border county, we're just working with the other counties. We do have some out-of-state situations with our kids in residential treatment centers. And those, we have the social worker fly out there. Usually there's a probation officer as well. And then they call in, and the facilitator facilitates from the phone, which I know isn't perfect, but it seems to work for the most part.
Okay. Thank you. Another one. What is a pathways worker?
This is the question I get too. So we have 20 designated workers who are pathways to well-being workers that came after the KDA CCR was released. So they specialize in getting mental health services connected with youth in our care, as well as doing the mental health screenings. So now that the CANS has replaced the mental health screening tool, they're doing the initial CANS for us.
And the Pathways to Wellbeing, we call them liaisons, coordinators, they're under CWS.
Right. And then Behavioral Health Services also has Pathways experts who help link up with the mental health services.
Right, and provide TA to our providers.
Oh, okay. Great. Okay. Someone commented, Viva la CANS, so just so you know. That's they like it. They like it. I think we have some questions about sharing policies and MOUs. I know that in the past, San Diego's been kind enough to share some documents with us that we have in turn shared with some of our participants on the call. Maybe we can do a side conversation later and reach out for any that we may not have and see if there's some you're open to sharing.
Yes.
Dan? I think we had a question about the court. I believe that one was already answered. You addressed that. We talked about the sharing of MOUs. Do you have any others? Does anyone want to raise their hand if there's any folks on the line that want to ask verbally a question? Please raise your hand. Haven't see anybody? Jeff?
Robert Bird is unmuted.
Robert, good afternoon.
Hello, how are you?
We can barely hear you.
Okay, I'll talk louder. I was wondering how the claiming for the behavioral health part of the CANS is being done, or how the state's reimbursing for that.
Oh, the claiming.
Yes. So currently, and if you're speaking to the completion of the CANS, based on the fact that we are encouraging clinicians to have the discussion during the client plan, it's really during the client plan session that they're claiming that service in time. Does that answer your question? So we're not doing a separate claim, and I know that there's I think the 1982 B or C, but we're not doing that external claiming. We're just encouraging the clinicians to incorporate that within their client plan session.
Okay, great. Anyone else with a raised hand? Question? Okay, fantastic. I think we have. Well, here I have another one. Is behavioral health doing the trauma questions in CANS for children 0 to 5 years old?
So the early childhood CANS, yes, it does include the trauma questions.
They're using the same version.
Right, we're going to use the version that CDSS has released.
And behavioral health will be doing that on child welfare's behalf. Okay, great. Nice to hear the collaboration there.
Gina Cook is unmuted.
Gina, can you hear us? Do we have a question?
Yes, hello. I was wondering if the CANS is used directly to write the court report.
Well, the CANS conversation in the Child and Family Team meeting creates the action items, which then become the case plan. And we're being really clear, you know, there's more action items than case plan items. So we're being clear when those are charted, which ones are case plan items. So, and then if for any reason that information that the finalized CANS, the parents didn't agree with it, or the child, one of the scores or recommendations, then we're being clear about that on the court report. So yes, we reference that a CANS occurred, we state what day it happened, we attach it as mentioned, and then it's used to create the case plan.
That's what I thought. Thank you.
Fantastic. If we don't have any other hands raised, I think I have one here in the chat box. Are you using the CSEC module for CANS? And if not, how is our commercially sexually exploited children population addressed?
Yes, we are using the CSEC module for the San Diego BHS CANS.
Okay. Thank you. We are, as far as chat box questions, do we have any other hands raised?
So Ultra had her hand raised, but she didn't enter her pin.
Oh, okay. So Ultra,
Hello.
if you have a, hi.
I had a question. Yeah, you mentioned earlier that your county does the CANS assessment for the 0 to 5. Do you guys do the 6 to 21? How do you guys handle those?
Yeah, so the San Diego CANS, which is the CANS 50 with the additional modules, it's administered to youth, children and youth 6 to 21.
Same for child welfare. Okay. We use the IP version.
Okay. All right. Thank you.
I have a kind of a two-part question, which I think maybe you've addressed the second part, but I'll go ahead and read the whole thing. How does San Diego provide completed CANS to the parent and child, and what do you provide to the court related to CANS?
Right, so we do attach the court report, and that's actually how most parents and children receive the CANS. We do verbally offer to provide the parents and the child a copy of the CANS, and then if they request it, we can give it to them sooner than the court report.
Okay, so they get the same copy that's being attached to the court report. Great. I think we are getting difficult stable terms. We have that. How is San Diego County Behavioral Health Services reimbursed for completing the early childhood CANS since it was not required by DHCS? Can you talk a little bit about how that works?
Right, so we haven't implemented it yet, so the implementation date is 7/1/19. And so as I stated before, the way that we're encouraging our providers is just to incorporate into a session, but I believe that there could be further discussions about claiming it separately if there's benefits to that. So this could be a side conversation.
Okay. Okay. Any other hands raised? Okay. Fantastic. All right. We don't have any other questions for our presenters. I want to thank them. Oh, there we are. Thank you, Shelly and Eileen. Heidi, thank you very much for participating and sharing your experience with the CANS. I especially like the personal stories that you shared, reference to the young man who became engaged once he learned it was about him and was able to share his own ideas of where he was in regards to numbers. I think that really helps with the communiometric piece of the tool when we engage our youngsters in the process as well.
Thank you.
Yeah, thank you so much.
Thank you. We have just a couple of minutes. One thing that we skipped over were the rest of our updates. So you want to talk about your?
Sure. I'll just briefly share an update on our CFT Implementation Team. The implementation team meets monthly with a focus on quality child and family teaming statewide. And during this month, we spent the majority of our time together stepping through some work that the child welfare directors have been engaged in regarding the core practice model. So we utilized a snapshot tool that had been developed for the core practice model, but really is able to be adapted to any type of implementation effort. And the tool is something that we're happy to share out. Oh, thank you for pulling that up, Jeff. So it really paints a picture of where you are, what the current state of implementation is. And in this case, we used the snapshot tool to look at CFT and CANS implementation for the counties who were present during the implementation meeting. So this snapshot tool looks at organization and leadership, workforce development, communications, and data. And really, again, just helps identify where you are and what priorities might be to move implementation further. And then beyond that, we looked at an implementation plan template, again, that the child welfare directors have been developing for the core practice model. And what we're going to be doing with that is stepping through it to really think about how it can be adapted for use at both the county level for CFT and CANS implementation, and then also at the state level. So that is ongoing work for the implementation team. And then finally, we spent some time in our subcommittees. We have two subcommittees. One is focused on workforce development, and the other is focused on communication and messaging. So we spent time in those groups identifying strategies and tools using the implementation drivers to identify how to best support counties, their staff, and supervisors and leaders in their implementation efforts. And then on the communication and messaging side, working to create craft messages and think through other strategies like videos and sound bites that can help create a shared understanding of the purpose and value of CFT and CANS. So this is ongoing work, and I will happily share an update during our next monthly call as well.
Okay. For the end of the day, we like to do one quick poll to our audiences today. So if you are available, I have launched the poll question.
Great, and while we're doing that, we also have an update from the Department of Healthcare Services, Dion Maxwell. You should be unmuted.
Hi, this is Dion. I just wanted to make one comment about the claiming with the 1982B and the 1982C forms. If you can at all possible, you want to claim through that system, you get reimbursed more quickly than you do through regular claiming. So I would highly advise doing that. It's a difference of between 2 to 6 years. So you get reimbursed 2 years on the POS claiming system versus about 6 years versus the other way. So if you can, I recommend it.
Oh, well, thank you for that.
Sure.
A huge difference. Okay, and how have you been on responses?
So we're about 60 minutes, so I'll go ahead and close it, share with you. We have, what we showed today, we have 46% is from child welfare and juvenile probation, and 35% from county behavioral health, 7% specialty mental health service providers, caregivers, trainers, or other, and then 6% of the audience is STRTPs and group home providers, and also 6% of foster families, FFAs. So a nice crowd.
Great. Well, thank you, everyone, for your participation. Thank you again so much to the presenters.
And the next convening is on Wednesday, May 1st.
Excellent. We'll see you then.
Thank you. Good afternoon, everyone.
Thank you.